This episode of the Black Doctors Podcast is brought to you by Empath IQ. Empath IQ provides reputation management and marketing tools to improve relationships between you and your patients. Their software platform encourages and curates positive reviews, enhancing your online reputation. Visit www.empathiq.io and mention the show to receive a special discount just for signing up. Check out the show notes for a link to their website.
The Black Doctors Podcast highlights the stories of minority professionals with the goal of inspiring others. If you like what you hear, please subscribe and share with others, because the next generation can't be what they don't see. Tune in every Monday to hear our stories told by us.
Hello and welcome back to the Black Doctors Podcast. I'm Steven, your host. This episode, I'm so excited to be speaking with Dr. Carmel Bogle. She is an advanced pediatric cardiologist, and she's currently practicing in Maryland. She's also a fellow alumni of Howard University College of Medicine. She was a year ahead of me back in medical school, and even was my senior on my one of my medicine rotations. So Dr. Bogle, thank you so much for joining us.
Thank you so much for having me. That podcast is so cool. I've been listening to it, and I feel honored to join you.
Awesome. Well, I definitely want to get more perspective from the pediatrics folks. I've neglected the kids, and that can't happen.
Don't forget about the children. No, you've done some good.
So, Carmel, let's start with your story. What initially drew you into the field of medicine or into healthcare?
I think my dad was the big inspiration for me for medicine. He was sick a lot growing up. He was a black male that grew up in Nashville, Tennessee in the 1930s, and he had rheumatic fever. And at that time, he didn't get medical care because he wasn't available to get medical care. And then as time passed on, he didn't really go to the doctor, and then had rheumatic heart disease and subsequent congestive heart failure. So I have a lot of memories in the hospital when he would have acute on chronic heart failure. So it really inspired me to want to go into medicine and go into cardiology too. So I think they made it a great experience of someone where you're in the hospital a lot, but they made it not a scary place, but like an interesting place to learn.
Yeah. So how old were you when you kind of realized that he was sick and that he was going in and out of the hospital?
I remember, I think my earliest memory is like 6 or 7 or so. It feels like he went in pretty often. So me and one of my friends, like when we did our coloring books, we did the Grey's Anatomy coloring books. So we were like nerd alerts early in life.
And that was in Tennessee?
No, I grew up here. So he's from Tennessee, but it was in Silver Spring where he would come to a lot of Washington Hospital Center was his like go-to.
And obviously that was an incredible impact on your life at a young age. And initially when you went to college at the University of Pennsylvania, you studied nursing. Did that kind of draw from those formative experiences?
Yeah, for sure. And in high school, we had a medical, I forget what the term is called, but a medical, if you had an interest in medicine, you could do medicine early in life. So in high school, they taught us medical terminology. I worked with child life specialists then, and I became a certified nursing assistant in high school. And then I went to college and was learning about like poli-sci as a pre-med and all these kind of general courses. And then my friend was in nursing school and was talking about her patient interactions and learning anatomy and physiology. And I decided to transfer to the nursing school after my first year because I just wanted to do more patient interaction at the time. And then my plan was to do pre-med nursing. And then I learned more about nurse practitioners and clinical nurse specialists. So worked as a nurse for a couple of years to decide which area of healthcare I wanted to go into.
Yeah, so interesting. So I think for 5 years, you said you worked as a nurse. And what kind of specialization did you do? Were you med surg or?
I worked
peds?
I was all peds. I worked in pediatric emergency room at CHOP, a hospital in Philadelphia. And then I came back to the DMV area and worked in pediatric sedation while I was kind of finishing up my pre-med classes.
And after finishing college, so what courses did you need to finish up in order to apply to medical school?
I took biology, orgo, and physics, I think were the courses. And I think I took a genetics class too, just to try and get them to like me a little bit more in medical schools.
So after practicing as a nurse for a couple years, what kind of led you to continue on into medical school?
I think I liked working with patients, but with nurses, you work really, really closely with patients. And I think after a couple of years as a bedside nurse, I felt a little bit limited where I wanted to have a little bit more autonomy in the decision making for the patients instead of just like implementing the orders. I wanted to actually do the orders and do medical decision making. So that's what caused me to want to go back to finish my pre-med classes and pursue medicine.
Yeah, so Dr. Bogle, it's interesting. So your family, you kind of grew up in the DMV and you ended up coming back to Howard for medical school. What went into your decision to attend Howard?
I had a couple of friends who went to Howard for other specialties, for social work and pharmacy, and they had a really great experience. And I feel like one of the tenets of Howard is to serve the underserved, and that was something that was really important to me. And I love the DMV area. I think it's such a unique area in the country where it's so diverse, both racially as well as socioeconomically. And I wanted to be able to take care of that patient population. In addition to the fact that my dad was continuing to be sick, so I wanted to be kind of near him in case anything was happening or went wrong. So I'm glad I was able to be part of Howard.
During the 4 years of medical school, were you always set on going into pediatrics, or did you consider other options?
I think I briefly considered emergency medicine and briefly considered surgery, but I think I was pretty set on, especially third and fourth year, really honed in that I do continue to like working with pediatric population compared to the adult population. So, yeah.
Yeah. And I think you'll be interested. I was just in Howard to speak with one of the student organizations. I stopped in and saw Dr. Forrester.
Oh, nice.
So we chatted for a little bit.
Well, that's awesome. I love her.
She had such an impact on students and especially, folks going to peds. So when it came down to matching, though, you matched into pediatric residency at Stanford, incredibly impressive program, but it was all the way across the country. So how did you deal with that change?
I think it was a big shock when I matched at Stanford. It was definitely like my pipe dream where I was like, oh, this would be great to go to Stanford one day. And then when I matched there, it was super exciting. But then all of a sudden I was like, I have to now move across country. And what am I going to do with all my stuff? And I think initially it was challenging because the East Coast, West Coast cultures are a little bit different. But the residency and the people at my co-residents were amazing. And I shortly made like my own little family there. So it was really great. And I feel like they implemented some more healthy practices than I might have otherwise had, where I got into running and just eating a little bit better. So some of that California healthy lifestyle rubbed off on me a little bit. So I'm really grateful for my experience there.
Yeah. When you think back, what was one of the bigger challenges that you faced during residency?
I think just residency itself is really challenging in itself. You have hard hours, you have a lot of information you have to learn at once. And I think I underestimated the amount of support you would need. So I think especially the first year and a half or so, going through those really hard times and not necessarily having to also create your own friendships during like an already busy season was, I think, challenging in itself, because I had to just rely on the people I had, and I'm grateful I had great co-residents, but I think it was hard to kind of find my place in that area at first, especially because everything was so new. I didn't know anyone going to California. So it was challenging to just kind of reinvent your social network there.
Yeah. Was it a large program, medium size, or small? I imagine medium or large.
I'd say it's probably medium to large. I'm like dating myself. I think it was a little more than 20 residents per class. So it definitely had a lot to pull from. And it ended up I had a roommate there, and she ended up being a really close friend that I still keep in contact with now. So it definitely made some great lifelong friends through Stanford.
And then that's not enough training yet. You had to go on and do some additional training. Did you know when you started residency that you wanted to specialize in pediatric cardiology?
Yeah, I knew I wanted to specialize in cardiology. At the time, the match, you had to apply your second year of residency. So you had to kind of go in intentionally starting residency of like having a research project and having good mentors to set up. So I had to be quite intentional about that when I started residency. And I had great mentors at Stanford, certainly great exposure to a lot of different patient pathology as well. And Stanford itself had like really great programs to empower you, whatever direction or you wanted to go into. So they were really great in supporting me in that.
Yeah, so you finished up residency out in California and you matched and moved kind of halfway back across the country. You ended up at Lurie Children's in Chicago, Illinois for your pediatric cardiology fellowship. What was your experience during fellowship?
It was great. I thought residency was hard and fellowship was certainly challenging as well. I was thinking it'd be great, since I'm really interested in cardiology, to just learn that subject. And it was really cool to learn the details of all of cardiology, but was certainly even more challenging than I anticipated compared to residency. But I feel like it definitely helped mature me as a clinician and helped mature me just as an adult with the gravity of responsibility you carry with those fellowship years. And I think looking back, it's still my foundation I pull back on as an attending now, where I got to learn great experience, but had great teachers and great co-fellows too. The program itself was a lot smaller to pull from. I think we were lucky we had 4 fellows in our class, but usually it's 3 fellows per class. But all my co-fellows were really close, and they were like a really fun group of people. So like we still send memes to each other and stuff. So that makes a huge difference.
Yeah, and how is that 3 years of training broken down? Like you went through different rotations, I assume. What all did you learn during fellowship?
Yeah, so we learned the different parts of subspecialties in cardiology. So we rotate with echo, which is like the ultrasound of the heart. And then we learn electrophysiology, where we learn the different arrhythmias, as well as going to the electrophysiology lab, where if there's an extra pathway in the heart, they find it and ablate it. And then we also learn cardiac catheterization, CICU, cardiac intensive care unit, and heart transplant, heart failure. So we kind of rotate throughout those, as well as just general cardiology. So we rotate throughout the 3 years. And then with each year, if you're interested in a subspecialty, you get to spend more time doing your subspecialty or general cardiology, if that's what you're interested in.
So as a general pediatric cardiologist, what are some of the most common issues and pathologies that you treat?
So we see a lot of congenital heart disease. So patients that their hearts weren't formed properly. So that can range anywhere from atrial septal defects or ASDs to ventricular septal defects, what we consider kind of the bread and butter of pediatrics, to taking care of patients that were born with half a heart or their heart's on the wrong side of the body. So you care for all that as a pediatric cardiologist. From some people do fetal echocardiogram, where they can diagnose that while they're in the womb. And then we take care of them.
Whoa. You said fetal echo. So the baby's in the uterus.
Yeah, and they can screen and detect if they have congenital heart disease. It's pretty amazing. I do not have that skill, but it's pretty cool that they can say, okay, this patient's going to be born with half a heart, so that the family can be kind of informed about the pathway in the future for them. And
you just put a probe on mom's belly and.
Yeah, they just put a probe on mom's belly, and it's a little challenging because obviously if the baby moves, you just have to chase it around a little bit. But it's pretty cool to see. It's definitely continuing to grow. But yeah, it's pretty cool that nowadays, I think before a baby would come out blue and you're like, oh no, what's the matter? And have to do an emergent echo on them. And that still does happen, especially for patients that might lack prenatal care. They obviously can't get everything with fetal echo, but I think that's helped a lot of diagnosis, especially for what we call cyanotic heart diseases, where they need intervention pretty early in life.
Wow. And I think as you guys obviously get better at what you do, we have kids with congenital heart diseases that are living to adulthood and living these full lives.
Yeah.
How does that transition occur in their care? Are they managed by pediatric cardiologists, or when do they transition to adult cardiologists, if they do?
That's a good question. I think that changes by center, but there are adult congenital heart specialists. So usually those people are either med peds, where they went through med peds residency, and they can either go through adult cardiology fellowship or pediatric cardiology fellowship. And there's an additional subspecialty fellowship called adult congenital heart fellowship. For the most part now is the path that people go. I think people that are older, that have kind of been doing this for 20 plus years, they just kind of fell into it. I think we usually transition around maybe in their 20s at some point. Sometimes some practitioners hold on to them a little closer if they have formed a bond with them. But generally speaking, the goal is to transition them kind of after college or so. to an adult congenital specialist. So we see them.
That's cool.
Yeah, it's cool. Like some people that have been doing this obviously a lot longer than I have seen people from birth to adulthood. I think one person saw like their kids too afterwards, like for screening. So it's kind of cool to have a subspecialty that you can still kind of have that primary care like longevity with the patients.
So Dr. Bogle, as a fellow, here's a question I haven't asked, but I had some requests to kind of talk about this. As a fellow, you worked with residents?
Yes, we worked with residents. Mm-hmm.
How was the interaction between you and those residents? What were your expectations and how did that, I know it's different for each program, but what was the interaction like for you?
I enjoyed it. It was nice to teach the residents. Cardiology is such a subspecialty field. You obviously I tried to change my teaching based on what their interests were, because if someone's going into endocrinology, they might not need to know all the stages of a single ventricle palliation. That's not really relevant for their future. So we taught them how to read EKGs, because I don't think we get a lot of education in that in residency, but it's really important. People are really interested in learning about murmurs and what those might represent. So I think we did a lot of bedside teaching, especially when they were on the rotation with us. And then we also tried to do, I don't remember the interval, but teaching about EKGs and then kind of just the general cyanotic heart diseases that you always get tested on the boards and are important to identify, especially early in life if you're working in the ER pediatric outpatient, for example.
Yeah. Well, what would you say was your expectation of those medical students and mostly residents that rotated on your service?
I think for the most part, I had an expectation for them to want to show some interest in it, even if they weren't going to go into cardiology, and try and take a stab, for example, of reading the EKG on their own, or trying to measure something called the QTC interval that we measure on the EKG machine. Because I think sometimes it's easy to just say, hey, we have a kid that has a murmur. Can you figure out what's the problem? And wanting them to take a couple steps beyond that to say, okay, well, what do you think it is? What's on your differential? Or what do you think this EKG represents? Because some of those skills you should possess as a general pediatrician. So I think just having the ownership a little bit of to think through a little bit, besides just identifying this is a cardiac problem, to think through kind of what cardiac problem you might think it is, or what big bucket, cyanotic or acyanotic disease is. Is this an arrhythmia or not an arrhythmia? I don't expect them to know the history of congenital heart disease or all the pathways of it, but just having an interest in taking somewhat ownership is my expectations I had.
It's good. It's fantastic advice. So Carmel, fellowship wasn't enough. At the end, you went on to pursue additional training in advanced cardiac therapies at Boston Children's Hospital. At what point did you decide to go on for that extra training, and what led you to make that decision?
I was interested in working with heart transplant and heart failure patients pretty early on. I think that was an interest I had in residency, which is part of the reason why I was really grateful to work at Lurie Children's, because the director there at the time, Dr. Paul, was like a big mega person in pediatric heart failure, heart transplant. So it was really cool to work with her. So I had that interest early on in pediatric cardiology. At least right now, a lot of times you have to do something beyond just general cardiology. You have to have a subspecialty. So it's not uncommon that people have to do 4th years. And I really liked the aspect of heart failure and heart transplant, because you've got to be in both worlds, meaning that you could help families and patients during a really acute time when they might present an acute heart failure, and you had to help them in the ICU and navigate if they needed a ventricular assist device or needed to be put on a heart transplant list. But then you also got to work with families if they did have to go through that route and needed a heart transplant, that you could then work with them in more of like the outpatient setting, where you're just kind of checking in every couple of months to see how they're doing. And some of my mentors have had the pleasure of seeing their patients graduate college, get married, go on to do jobs. And so it's kind of cool to see both that acute and outpatient setting, which I think is pretty unique. And I think although adults have been doing it for quite some time, the ventricular assist devices or machines to kind of help people with failing hearts while they're waiting for a heart transplant has really taken off, I'd say, in the last 10 years or so. So I think it's been cool to kind of be part of that community where that's becoming less of a rarity and more of kind of a mainstream, or at least an available option to a lot of patients that otherwise might have not made it maybe 20 years ago.
Yeah, it's pretty incredible because these ventricular assist devices, I worked with them a lot at University of Chicago in residency, and they're big, right, for adults. And over the years, you can see how they started large and they started getting smaller and smaller. So when
Yeah.
it comes to pediatric patients, have they just gotten that small, or are there pediatric-sized ventricular assist devices?
There's some pediatric sized ventricular assist devices. The Berlin or S-Core is one that is, I don't think adults use that. And they have sizes based on the patient's weight. And then we use a lot of the adult data, like heartmates, for like our teenagers or preteens, kind of depending on the size. I think they've been continuing to work with making a new ventricular assist device for babies that are very small, because there are some more limited devices for like neonates or really small babies. So that's still something that they're continuing to work on to optimize.
Wow. Yeah, I can't even imagine ventricular assist device in a neonate.
Yeah. So kids are pretty cool though. It's like you'll see them like really sick, like right after they get their ventricular assist device. And then especially the Berlins, it's a extracorporeal device. So the device is outside the body, so you can see the blood going in and out of the pump. And it's cool to see that like postoperative day one, they might be sedated and intubated. And then as they're kind of waiting for their heart, they get better, like they're like playing, they're jumping around, they're like playing, like they're doing all this stuff with this Berlin, where like usually the nurse or someone has to kind of follow them around with their actual machine. So I feel like that's part of the reason why I love kids, is because like I don't imagine you might see that with adults as much. Like kids still want to be kids no matter how sick they are. So it's cool to try and help them do that and help their development, even though they might be really sick.
So you let them ambulate with the device?
Yeah, it's pretty stable. So you're like having palpitations over it. But yeah, it's like stable. So yeah, they can definitely ambulate, they play. Yeah, they can do a lot of stuff with it. So it's cool.
And for the folks that, to kind of conceptualize this, since it's on a podcast, the access is through the jugular? Is it, or
no,
how are they accessed?
They're accessed through the like it's an open heart surgery. So they have the device, and then they have what we call the drive lines that come out of the body, but it's in the chest wall area that they have two what we call kind of drive lines or tubes that come out of their body. So the pump for the Berlin specifically is outside the body, but it's in the chest area.
And these are mostly bridge to transplants?
For the most part, they're bridge to transplants. I think for the Berlin, it's definitely a bridge to transplant, at least at this point. But for some of the patients that have a heartmate, those can be sometimes bridged to what we call destination, or patients that just have a ventricular assist device, and sometimes they elect not to undergo transplant, or for some other reason they might not be a transplant candidate. So sometimes these patients are just on it for the duration of their life. And some people have preferred that instead of going the transplant route. So it's been a nice option for them.
And so how long was your Advanced Cardiac Therapies fellowship?
It was a year.
A year.
Intense year, but it was really great. I feel like I got to work with like these rock stars every day. So it was a really great privilege to work with all of the people there.
Fantastic. And then you'd finally had enough training, and you started working in Maryland, and you got a job in academic medicine. What was that transition like?
It was definitely challenging to all of a sudden kind of be on your own, especially after kind of being a chronic student or trainee for like 7 years. It was nice to kind of be on your own, so that if you had an idea, people all of a sudden listen to you a little bit more. But it was also, a little scary to not necessarily have someone to be like, hey, this is what I think. Is this okay or is this not okay? And you obviously fall back on your mentors, but it definitely made me put my big girl pants on a little bit more, where I really had to be confident. And I think it challenged me. In medicine, you always are wanting to stay abreast in the research and stay abreast in the newest guidelines, but especially I think kind of being out on your own, you really want to make sure, it encourages you even more to stay on top. And it's been nice. One good thing about the pandemic is I think the virtual conferences and virtual learning sessions have been more accessible than I think they were before. So it's been nice to kind of be part of the Pediatric Heart Failure and Heart Transplant Society, because we have like monthly meetings, monthly educational meetings, and a lot of subspecialty groups if you have an interest in it. So it's really, to me at least, brought the community closer, even though we're all in different areas.
That's fantastic. And so what's a typical week like for you?
So I have training in advanced cardiac therapies, but I also work as a general cardiologist. So usually during the week, if I'm not on inpatient, I see outpatients usually 3 or 4 days a week and see them in clinic. And it can range from people that just have some chest pain or palpitations or dizziness to patients that have one side of their heart that is on different stages of in between surgeries. And then I also take care of my heart transplant patients and keeping up with them and all their surveillance as well. And then I read echoes 1 or 2 days a week as well. So it's been a good diverse of tasks to do.
Busy. Are you working 5 days a week or 4 days a week, an academic day, or how's that?
Yeah, I usually work 5 days a week or maybe 4.5 or half a day. I can catch up on clinical work or research. But yeah, for the most part, it's usually like 4.5 or 4 to 5 days a week. We're on call every once in a while. So when we're on call for that night, usually we get the day off, which is nice to kind of take a rest. So it's been good.
When you're on call, it's over the phone?
Yeah, it's over the phone call with the possibility that you might need to go in if there's like an emergent echo or something emergent happens. But it's by phone at first, at least.
You mentioned that there's other subspecialties for pediatric cardiology. What are some of those subspecialties?
So there's advanced cardiac therapies, which takes care of the heart failure, heart transplant children. There's echocardiogram, where they can specialize in reading echoes. And those are usually the ones that specialize in fetal echocardiogram or doing cardiac CTs or MRIs. There's cardiac catheterization. There's cardiac electrophysiology or EP. I feel like I'm missing one more. There's also a preventative medicine that you can do, or some of the subspecialties, and then CIC or ICU if you want to go into being a CICU trained doctor.
Wow. Yeah, I had no idea that all those subspecialties.
Yeah. Just like to make it as complicated as possible for everyone.
So let's talk about healthcare disparities, because, a lot of these kids that are sick, probably or maybe don't have the best insurance and, are obviously probably can't pay for this out of pocket, or their families can't. How does the system work that folks that don't have means are able to get the care they need for their kids?
I think, at least from a pediatric standpoint, I think we've been fairly good with that, so that if someone doesn't have health care, we'll find a way to either, especially if it's emergent, we'll find a way to cover it, whether that's the hospital absorbing the cost or putting them on emergent Medicaid. So I think for the most part, we don't turn patients away for any procedure they need, especially if it's emergent. I think sometimes if their insurance lapse, then we kind of do whatever we can, working with our social workers or working with the primary care to get them in as soon as possible. So I think that's one cool thing about pediatrics is we certainly won't ever turn someone away if they need emergent care. And I think especially sometimes if they can't afford their medicine or their copay is too high, I think we definitely work with them to try and make sure that they meet those needs. And so, a child shouldn't have to suffer just because the parents, no one should actually have to suffer if they can't afford it, but especially children where they really truly have no control over it, have really come together. So I think that's been helpful. I think it's been cool one thing I like about the job is just being able to educate families, especially those that might not be exposed to medicine, since medicine is really complex for a healthcare provider, let alone someone who has no experience or might have limited healthcare literacy. So just trying to break down those topics, to break down like, this is a picture of a heart, this is what your child has, and kind of acknowledging that people may retain 30% of what you're talking about anyways. So the fact that we get to see these patients fairly frequently can kind of hopefully hone in the message and educate them.
That's good. Yeah, thanks for kind of breaking that down. And it's incredible to hear your story and the progress that you've made since we were last rotating together on the wards at Howard University Hospital.
Yeah, it's been cool.
So looking back, what would you tell yourself all those years ago as a medical student, just starting out the process? I was speaking with some of the students at Howard, and a lot of them were kind of confused, didn't know what specialty to pursue, where to go from medical school. So what would you say to kind of help make recommendations? Should they focus on subspecialization or stick with basic specialties, or how would you help somebody navigate this?
I think if they have an interest in pediatric cardiology or if they have an interest in a subspecialty, I think it's helpful to talk to those subspecialists. And I think a lot of times I think at Howard and other undergraduate communities, I've certainly been reached out to by some of them just to talk to them for 30 minutes or so and just get an idea of what their job is, because I certainly didn't know all the subspecialties as an undergrad. And sometimes it's a subspecialty you never thought of that might be something you end up doing for your career. So I think the more exposure you get, the better. I think when you're in medical school, you don't have a lot of free time. So like giving yourself realistic goals, I guess, of like this semester, I'm going to talk to one person of a subspecialty interest I have is helpful, especially your first 2 years, and using those electives during your clinical years to really see is this something I actually want to do? Especially in pediatrics, I think sometimes people say, oh, I like working with kids. I like babysitting. And then they go into pediatrics and they're like, oh, this is actually sick kids that like are crying or bleeding. So making sure that liking of kids translates to liking sick kids and working with sick kids' families, because it's different than maybe playing with them at a camp or doing babysitting. So I think getting that clinical exposure is really key, because you're going to be doing this for, 15, 20 plus years. So making sure you like it.
Very helpful. As we wrap up, so Carmel, one of the interesting things about you, besides you're just an awesome person, and we bumped into each other a couple times in Chicago and over the years, but you invented a holiday.
Yes, it's an international holiday. It's called Narwhal Day, and it's a day to celebrate the unique people in your life, since narwhal is a unicorn of the sea. So it's been celebrated in California, Chicago, Italy, the DMV area, and beyond. So thank you for allowing me this platform to allow it to go even further.
So what day is Narwhal Day?
Narwhal Day is March 24th, and it will be an upcoming Thursday in 2022. I can't believe it's 2022 next year.
Time flies. I'll definitely keep it on my calendar, because I think I missed celebrating this past Narwhal Day.
Yeah, that's exciting. We'll have to, everyone can flood the Instagram feeds on Narwhal Day.
There we go. Well, Dr. Bogle, thank you so much for coming on the podcast and sharing your incredibly unique and inspiring story about becoming a pediatric cardiologist.
Thank you so much, Dr. Bradley. It was an honor to be on your show. I hope you have a happy day.
Awesome. And folks, thanks for joining us. Tune in next week, because representation matters.
The Black Doctors Podcast is a nonprofit, volunteer passion project with the goal of inspiring all who listen. Tune in next week for another episode of the Black Doctors Podcast with Dr. Stephen Bradley, your friendly neighborhood anesthesiologist.